Hello, everyone. It's good to be back at my favorite peripheral conference of the year. Thank you, Dr. Craig Walker, for inviting me again. It is an honor and privilege. Today, I'm going to be talking about a little controversial topic, which is the common femoral artery intervention. Should we do endovascular intervention or surgery? I have no financial disclosure for this talk. So endotrechtine has remained the gold standard therapy for common femoral artery lesion ever since we started this surgery back in 1950s. There are some theoretical concerns when it comes to endovascular intervention for common femoral artery, because where it is located right at the hip joint, which is a very high flexion point, there's always a risk for stent fracture in that area. And also, it is an access point for a lot of cardiac procedure, for example, complicated PCI and TAVR. And the concern is that we don't want to put a stent in that area and shut the door for future interventions. So I call a lot of my vascular surgery friends around the country to kind of see what they are doing, what is the data. So 2 days ago, I called Dr. Fahad Shuja, great friend of mine. He's a vascular surgeon at Mayo Clinic. So he actually sent me this case, which he performed 2 days ago. They have 70 years old lady with history of diabetes and chronic kidney disease. She presented with CLI. She had a previous FEMPOP bypass surgery 4 years ago with profunda ligation. Now, don't ask me why she had profunda ligation, but her surgery was complicated 4 years ago by a lot of wound infection, descents, and back. So she had a pretty complicated post-op course. So now she is presenting with the left common femoral artery stenosis. As you can see, the ultrasound, it looks pretty tight. So this whole case was performed without using any contrast. It was under IVUS guidance and CO2 guidance. As you can see, a very discrete lesion in the left common femoral artery. The bypass is patent. Still picture. So he did the IVUS, he performed the balloon angioplasty with 7.0 millimeter balloon followed by superstent. He also performed laser atherectomy, and this is what you see. So what type of lesion it is? So based on the CFA classification, there are two types of classification we can use. One is Medina classification that we got from the coronary data, and then you can also call it a lesion type, which can be type 1, type 2, type 3, or type 4. Like in the previous case, it was a pretty straightforward type 2 lesion. Again, if you look at this picture in figure A, you can see the mid-proximal CFA lesion called type 2, but then if you see more complicated lesion like in figure B, those are the cases most likely will need endotrechtine instead of endovascular intervention. But let's talk about the data. So what I will do, I'll start with surgical data, then I will go on with endovascular data, then we will talk about some comparison data. Again, endotrectomy has been performed since 1950, so I'm just going to start with more recent data. So this was the paper which was published in 2016 looking at the clinical outcomes of surgical endotrectomy for common femoral artery occlusive disease. And if you look at this data, not a lot of complications, not a lot of issues with mortality. There were some wound infection as it can be expected. But if you look at the patency of the surgery, especially in patients with intermittent claudication going all the way up to 7 years, patency can be as high as almost 95 to 100%. The limb salvage rate in the IC patient intermittent claudigans can be 100%. In the CLI patient, as you know, these patients are sick to begin with, 82%. And overall mortality or survival rate is very dismal in CLI patient. Again, these patients are very sick to begin with, but the patency data is amazing. Palota and his group, this study, it was a prospective study up to 7 to 10 years, and the primary patency was about 96%. Again, the patency rate was very good. However, these surgeries are not without its complication. It's not a benign surgery. If you look at this paper, it was a retrospective analysis. They looked at 1,800 patients from 2005 to 2010. The composite complication rate was 15%. Mortality was 3%. wound infection were 8%. And 10% of these patients, they ended up coming back to the OR. Again, it's not a benign surgery. So now look, let's talk about the endovascular data. Bombini and his group published these outcomes back in 2011, looking at balloon angioplasty on 355 patients. About 39% of those patients ended up getting bailout stent. At the end of the study, they also ended up doing some atherectomies. And if you look at the restenosis rate in these patients, in those who got balloon angioplasty at 1 year, it's about 26%. And the TLR rate was around 19%, which is not really great for balloon angioplasty. But those results were much better in those patients who had bailout stenting or atherectomies. Mehta and his group reported these outcomes back in 2010 in patients who had balloon angioplasty, atherectomy, or bailout stenting. At 20 months follow-up, the provisional stent group who had a bailout stent, they had a patency of about 100% at 20 months. Those patients who had balloon angioplasty only, 72%. Those who had atherectomy and PTA, 92%. So atherectomy definitely helps. Another study reported looking at directional atherectomy with anti-restenotic therapy versus drug-coated balloon angioplasty alone. At 12 months, primary patency and TLR favored DART, which is atherectomy plus drug-coated therapy versus DCB alone. And secondary patency was also significantly better in DART group. Then Siopa and his group reported these outcomes in 30 patients, in those who had directional atherectomy with drug-coated balloon therapy. At 1 year, the limb salvage, TLR, and primary patency were 100%, 6.7%, and 90% respectively. Great outcomes. Now, let's talk about comparison data. This was a landmark trial, randomized controlled trial. It was a French study, also called TECO trial. It was published in 2017. They randomized almost 117 patients to either surgery or stenting. And if you look at the lesion type, most of these patients had type 3 lesion, which was a distal bifurcating lesion, complicated lesions. And these patients, those in the stent group, all got self-expanding stent, but those patients who had a bifurcating lesion, they ended up getting balloon expandable stent so that they can deploy right at the ostium. The primary outcome, which was the composite of morbidity and mortality at 30 days, was 26% in surgery group and 12% in stenting group, which favored stenting. And that primary outcome, worst outcome in surgery, was driven by wound infection, lymphoria, and paresthesia. So the stenting people, those people who got stents did much better. Not only that, if you look at the patency at 2 years, it was almost similar, both in the stent group as well as the surgery group. And it kind of favored the stenting. Same goes from TLR. It was similar in both groups, favoring stenting. So based on this landmark trial, the TECO trial, the SCAI, the Society of Cardiovascular Angiography and Intervention, now have upgraded the level of recommendation for CFA stenting to 2A, which is pretty good. This was the review article which was published by Garcia and his group in 2019, looking at all the trials in the past. Again, there has been 2 randomized controlled trials directly comparing endovascular intervention stenting versus surgery. A linear trial was bioabsorbable trial, which was back in 2014, which favored surgery. But then the TECO trial, which I just talked about, which was a landmark trial, definitely favored stenting in the CFA lesion. Now, we have more and more trials ongoing. For example, PESTO CFA, which is led by Dr. Zeller in Germany, it is looking at directional atherectomy and drug-coated balloon angioplasty or vascular surgery, and we are eagerly waiting for the results of this trial in the next 1 to 2 years. So how should we approach patients? Again, it should be case to case. If it is a young patient and you see a lot of calcification, bifurcating lesion, and you need to preserve the access in those patients, the endotrectomy is definitely the first option. Again, it's a great patency data. I know that, we just talked about 15% of post-op surgical complication, but in that trial, they spent about more than 2 hours in surgery. Nowadays, when I talk to my surgeons, they said this surgery should not take more than 60 minutes. But then, like we talked about a patient from Mayo Clinic, if there's a risk of infection, like that lady, she had previous wound infections, or if she's morbidly obese, very sick people, older patient, and if it is a chip shot, class 2 lesion, then endovascular therapy has now a grade 2A recommendation. We can definitely do that. So in conclusion, the endovascular therapy has data showing it can be performed safely. Again, 2A recommendation. Surgical therapy also has a data supporting its safety and efficacy. Again, great long-term patency. I think we need more and more data. We need longer data which can compare the stenting versus surgery in terms of patency, say at 10 years and 15 years. Again, there's nothing wrong with endotrectomy. It's still the gold standard. Thank you very much.